Hello and welcome to Clinical Cases. Today we're going to be looking at the gastrointestinal system, and we're going to look at the first 10 clinical cases that are relevant. So we're going to be looking at in this video Peritonitis and Parotitis, Thyroglossal cysts, Esophageal atresia and stenosis, Pyloric stenosis, Biliary atresia, Splenunculus and Annular pancreas, Celiac disease, Irritable bowel syndrome and Diverticulitis. So let's get started by having a look at peritonitis. Now, in order to understand peritonitis as a clinical condition, you need to understand what the peritoneum is. So the peritoneum is a double-layered membrane that lines the abdominal cavity. So you can have a visceral peritoneum which lines the viscera, so the organs of the abdomen, or you can have a parietal peritoneum which is on the outside, so that lines the walls of the abdomen. And then we think to what, in general in medicine, what itis means, which means inflammation. So peritonitis is inflammation of the peritoneum. Usually it's caused by some kind of infection from a bacteria or a fungus. As a result, it can lead to poor appetite, nausea and vomiting, abdomen aches which can turn into pain as it progresses, chills and fever and fluid in the abdomen as well. Consequently, in the long term, this could lead to shock and acute respiratory distress syndrome, so obviously those are preventable things that we don't want to happen. And it can be caused by a variety of things, so peritonitis is normally secondary to something else, so for example secondary to pancreatitis, pelvic inflammatory disease, stomach ulcers, cirrhosis, ruptured appendix, etc. The risk factors for peritonitis link to the causes, so some kind of penetrating trauma to the intestine links to this perforation of the intestinal tract, twisted intestine, inflammation of the hollow abdominal viscera. We can diagnose this using examination, blood tests and imaging, and usually we can treat it with antibiotics if it's bacterial, with IV fluids, pain medication and potentially surgery if it really does need curing immediately, because it can cause death within a few days if we fail to treat this. So as we said, it can cause shock, consequently it can cause death. So moving on from peritonitis, we can look at the thyroglossal cyst. So a thyroglossal cyst is a fibrous cyst that forms from a persistent thyroglossal duct. So they can be defined as an irregular neck mass or lump which develops from cells and tissues left over from the formation of the thyroid gland from the development stages. So remember, normal thyroid development arises as endodermal diverticulum, and it arises from that foramen cecum at the junction of the anterior 2/3 and the posterior 1/3 of the tongue. Okay, and the thyroid migrates down the tract to reach its final position. However, in some cases, that thyroglossal duct can persist, and therefore you get these cysts. Consequently, can cause infection if they're untreated, and can cause a fistula if they rupture unexpectedly. So really, we want to treat these by removing them to prevent infection in the future. It's usually lined by pseudostratified ciliated columnar epithelium. And remember, the cause really does link back to the embryonic development of the thyroid gland. Next, we can look at parotitis. So this, again, looking at that last part of the word, itis, so you've got some kind of inflammation going on. And parot, so we can think of words that are associated here, so the parotid glands is what you think. So the parotid glands that are inflamed. So your parotid glands are your paired major salivary glands, the largest ones that are located either side of the face, so they're located outside the oral cavity, and their duct enters the oral cavity behind the second upper molar. So the parotid gland is the salivary gland that's most commonly affected by inflammation. Consequent things that could cause parotitis include dehydration, autoimmune conditions such as Sjogren's syndrome, blockage of the ducts, and infections such as mumps. Consequently, these parotid glands may swell, they may be painful, it can cause a fever as well as a result. So remember that normal parotid gland is outside the oral cavity, and inflammation of it causes parotitis. Next we look at esophageal disorders, so esophageal atresia and esophageal stenosis. So esophageal atresia is a congenital defect, which means it occurs before birth. And usually the upper esophagus ends and does not connect with the lower esophagus. So there are lots of ways that esophageal atresia can occur, and it's good to take a look at some of the diagrams that show the different types of esophageal atresia. So it often occurs alongside another birth defect called a tracheoesophageal fistula, which is a connection between the lower esophagus and the trachea. So I think this picture here shows that. So that's a tracheoesophageal fistula here. So it's a joining of that trachea and esophagus lower down But as you can see here, this is an esophageal atresia because the upper esophagus has just ended abruptly, and the lower esophagus just starts lower down and does not connect to that upper esophagus. But in the meantime, you form this tracheoesophageal fistula, which is connected to the trachea. So it's characterized by obstruction of the esophagus, and we describe it as a blind-ended pouch. As you can imagine, there's an end to it, and it's not really got anywhere to go. Symptoms include a bluish colour of the skin, coughing, gagging, and choking when they attempt to feed, drooling, and poor feeding. So it really is something that's detected at birth almost immediately. So before birth, a mother's ultrasound scan may show too much amniotic fluid, which is a sign of esophageal atresia, which may prepare you for this. So the normal esophagus, remember, it has cervical, thoracic, and abdominal portions, and it has 3 normal constrictions as well. So esophageal stenosis, this is a benign stricture, so a benign narrowing or tightening of the esophagus. So remember, you've got 3 normal constrictions, but this is an additional constriction of the esophagus, which is unexpected. It can be primary or it can be secondary, so maybe investigate the difference between those two. Next, we've got pyloric stenosis. So we're thinking about the stomach. The pylorus is in the stomach, and it's that end part of the stomach connecting it to the duodenum. So pyloric stenosis is this condition in infants that blocks the food from entering the small intestine. So obviously the whole purpose of that pylorus and that pyloric antrum and the sphincter is to allow that chyme into the duodenum, and this issue here is that it's not allowing food into the duodenum. So it's idiopathic thickening of this musculature here, which results in this obstruction. Okay, so stenosis, we're thinking narrowing or obstruction. Consequently, it can cause vomiting forcefully after feeding, which may contain blood. You may notice persistent hunger and stomach contractions because of that consistent vomiting after feeding, because that food can't get through to the duodenum. It can't be digested, there's a lack of energy, and so you're creating this persistent hunger because the food's not getting through. So we can diagnose this. Biomeal is a good way to show a pyloric stenosis, but also it may be palpated as an olive-sized mass in the right upper quadrant of the abdomen. The cause is usually unknown, but it is more common in boys. So next we have biliary atresia. So this is something that's really easy to understand if you understand the normal biliary tree. So understanding that coming out of your liver you have a left and right hepatic duct. These fuse to form a common hepatic duct, which joins with this cystic duct coming from the gallbladder. This then forms a common bile duct, which goes down towards the sphincter of Oddi, meets the main pancreatic duct, and releases the bile and the pancreatic enzymes within to the duodenum to aid digestion. So biliary atresia is a childhood disease of the liver, where one of the bile ducts or more than one of the bile ducts is abnormally narrowed, blocked, or absent, and so it therefore can be congenital or it can be acquired. And there are 3 different types really, so atresia of the common bile duct, atresia of the common hepatic duct, and so on. And it depends which duct is blocked, the impact that it has. So take a look at these 4 pictures here and match them up to type 1 appropriately, so you understand where the blockage is. Consequently, it can cause jaundice, so yellowing of the eyes and the skin. The sclera of the eyes particularly is a noticeable effect of jaundice. Darker urine than normal, hepatomegaly, splenomegaly, and the symptoms are normally seen between week 1 and week 6 of life. And again, the exact cause of biliary atresia, it is unknown. Splenunculus and annular pancreas are the next ones to talk about. So splenunculus is when there are small nodules of spleen that are separate from the rest of the organ. They're benign, they're asymptomatic, but it's important to know about them. They usually occur during embryonic development. So the most common location for an accessory spleen is to be at the hilum of the spleen and adjacent to the tail of the pancreas. So remember, the tail of the pancreas normally tickles the spleen, and it's usually found in actually up to 16% of the population. So it's actually really quite common. Symptoms, so it's asymptomatic normally, so it's not a massive one to be aware of, but in some cases it can cause abdo pain due to torsion and infarction. You can diagnose it with a CT, which is shown here. Annular pancreas, this is a rare condition where the second part of the duodenum is surrounded by a ring of pancreatic tissue continuous with the head of the pancreas, so it almost strangulates the duodenum. so it constricts the duodenum and blocks or impairs the flow of food for the rest of the intestines. It is embryologically caused. It's a malfunction of the GI development. For more information on the GI development, go to the physiology videos that are at the top of the page on the website. So it is an embryological malfunction. So symptoms, it can cause polyhydramnios, so excess amniotic fluid, so it can be detected early on, and it can cause feed intolerance immediately after birth as well. Celiac disease is another thing to be aware of. So this is caused by a reaction to the immune system to gluten. So this is a protein which is found in wheat, barley and rye. It's extremely restrictive in terms of what someone can eat. So when someone with celiac disease eats gluten, their immune system will react by damaging the lining of their small intestine. Consequently, it can cause diarrhea, excessive wind and constipation, nausea and vomiting which is unexplained, and stomach pain, cramping and bloating. It's got an increased risk with those who've got type 1 diabetes, thyroid conditions and ulcerative colitis. So there's quite a lot of food that contain gluten, so it really is restrictive on the diet, so cereals, bread, beer, french fries and so on. There's a lot of foods that really do contain gluten, and gluten-free options are available, but not quite the same quality essentially as standard gluten products. So it's an autoimmune essentially problem where it attacks the wall of the small intestine as a result of gluten. Next, we've got irritable bowel syndrome. So this is a group of symptoms essentially as opposed to one clinical condition, and it includes abdominal pain and changes in the pattern of bowel movements without any evidence of an actual underlying pathophysiological cause, and these symptoms tend to occur over a long time, often years. It can be classified into 4 types depending on whether the diarrhea is common, constipation is common, both are common, or neither occur very often. So it can cause abdominal pain and cramping, diarrhea, bloating and swelling of the stomach, and excessive wind. Okay. So in terms of epidemiology, it's prevalent in around 10% worldwide, which is actually quite a high proportion of people for it to affect. And actually it's much more common in women. 2 to 8 women are affected for every 1 man that's affected. Just be aware that in India the prevalence is a lot lower than the rest of the world, and actually it's more common in men in India. So in a history, make sure you're focusing on that food intolerance, what occurs when we eat certain foods. Be aware of this FODMAPs diet, which is outlined briefly at the bottom of the page here, but actually know this in a little bit more detail. Also be aware of the idea of non-celiac gluten sensitivity. So this has been hypothesized as an underlying mechanism for symptom generation in patients with IBS. So remember here in celiac disease we talked about gluten causing the damage to the inner lining of the small intestine. Here we're thinking potentially about a non-celiac gluten sensitivity, because gluten has been demonstrated to alter bowel barrier functions in patients with IBS-D, a type of IBS. Lastly, for this video, to look at diverticulitis. So these are pouches that occur along the digestive tract. So diverticuli are simply pouches that form, and these pouches tend to form weak spots in the intestinal wall which balloon outwards. Okay, and you can kind of see this in this image at the bottom here. So as a result, it can cause lower abdominal pain of a sudden onset. However, it can occur over a few days. There may also be nausea, diarrhea and constipation. And really, if the patient's got fever as well, it's suggesting a complication. Again, blood in the stool suggests a complication. There's not really one cause for diverticulitis, but usually the root cause is fecal matter, which is blocking the opening of the diverticuli. So if that fecal matter gets stuck in the diverticuli in that pouch, leads to inflammation and infection. But the reason for that blockage can vary from person to person. Typically, the risk factors for diverticulitis include obesity, lack of exercise and a low-fiber diet, smoking, family history and drugs, so particularly non-steroidal anti-inflammatory drugs. And essentially, remember, having pouches in the large intestine is known as diverticulosis, and only when they become inflamed is it known as diverticulitis. So it's that inflammation again with that itis, essentially. And it actually occurs in between 10 to 25% at some point in time of people, and it's due to a bacterial infection, so it's inflammation of those pouches. That's everything for this video. Join us next time when we'll continue to look at some more GI diseases. And as always, if you've got any feedback, it's greatly appreciated. Please do leave it in the comments below or message me personally. It's greatly appreciated. Alright, thank you very much for listening.